All right, well, we'll get started, and I want to thank everyone for joining us this afternoon for today's conversation, An Unequal Crisis, Addressing the Intersectional Dimensions of COVID-19. My name is Beth Chandler, and I'm the President and CEO of LeadBoston. And before I tell you a little more about LeadBoston and our program for today, I do want to share that the demand for this webinar was huge, so we apologize in advance if we have any technical challenges. We are going to do our best to keep everything running smoothly this afternoon. So to give you a little background on LeadBoston, for over 150 years, we have been dedicated to eliminating racism, empowering women, and promoting peace and dignity for all. Today, we engage individuals and organizations across the city to create more inclusive and equitable environments for women, people of color, and women of color in particular. As part of that work, our LeadBoston program is cultivating inclusive leaders with the skills and understandings of systems necessary to address disparities in all sectors. Our panelists, Dr. Julie Levison and Dr. Jonathan Jackson, are both alums of our LeadBoston program. Julie is co-director at the MGH Chelsea Healthcare Center Community Research Program, assistant professor of medicine at Harvard Medical School, and a member of the Infectious Disease Society of America. Julie's research focuses on understanding and addressing disparities in HIV outcomes in minority populations with specific attention to immigrant populations. Jonathan is founder and executive director of the CARE Research Center at Massachusetts General Hospital and Harvard Medical School. The CARE Research Center investigates the impact of diversity and inclusion on the quality of human subjects research and leverages deep community entrenchment to build trust and overcome barriers to clinical trial participation. His research focuses on midlife and late life health disparities in clinical settings that affect Black populations. Julie and Jonathan, thank you so much for joining us in today's conversation.
Thank you.
So before we get started, you both are human beings who are dealing with what's going on. And so before we get you to go into your clinical and scientific mode, I just wanted to ask, how are you both doing? Julie, do you want to go first?
Oh, sure. First, I want to say thank you to LeadBoston, to Beth, her team, and Jonathan for inviting this conversation. I can also see the numbers balloon on the bottom of the Zoom screen, and I can't tell you how heartening that is. I think one of the challenges in an emerging infectious disease crisis, or any kind of crisis, but particularly in this moment where we're physically separated, is the emotional consequences of that physical separation. So we're finding new ways to connect, and the fact that over 400 people so far logged in fills me with a sense of optimism and solidarity. It's that kind of feeling that gives me a new start, a restart, refresh button every day. And so I just want to communicate a tremendous sense of gratitude to being with all of you.
Thank you. And Jonathan, how are you doing?
Wow, Julie, that was a really elegant introduction, but I'm doing all right. I think, like many of you, I'm trying to balance a whole host of responsibilities that I had gladly left to other people. So you might hear a few noises in the other room as my daughter kind of does her homework, and the neighbors who are upstairs. So I think overall I'm doing well. About 4 weeks ago, I started presenting with symptoms of COVID, but since then I've bounced back. There were a few kind of scary days there. So for anyone who is now dealing with those symptoms or caring for a loved one or worried about those symptoms, I'm right there with you, and I hope that over the course of the next 53 minutes that we can bring some order to your world and help you figure out where we go from here.
Well, thank you, and thank you for sharing that you personally were affected. Thank you both for your opening comments. And Jonathan, can you talk a little bit about what you're observing at MGH in regards to COVID-19?
Yes, goodness. MGH, like many other hospitals or academic medical centers, is very much on a war footing, which means that Everybody who can be reached to help the effort is helping the effort. They're bringing in lowly PhDs like me to help with on the medical and the clinical side wherever possible. Not doing patient care, but I am handing out masks and trying to keep spirits up. But on the scientific side, which is really where I spend more of my time, I have never seen a more impressive redeployment of resources and focus of effort. It's difficult to get any two scientists to agree on what time it is or what day it is. But nevertheless, we see tens of thousands of researchers and thousands of research labs all singularly focused on the challenge of COVID. And I've never seen anything like this in my lifetime. I've never heard of anything like this in my lifetime. And I doubt very much we'll see this sort of singular focus again. It's truly impressive, the minds and the diversity of the minds that are at work on this.
Wow, thank you. Julie, any additional observations?
I really concur with Jonathan. I think despite whatever disagreements we might see in sort of the larger political landscape, as a medical institution, I would say on the whole, we are so resolute in our purpose. As a clinician, one of the things that we train for, and it was interesting when I was in the selection for residency, they used to say we pick people to who we want to be up in the middle of the night at 3 a.m. in a crisis with. Those are the people that you want to stand side by side. And so while one could have debates over whether we could foresee such an event like now, I think in many ways, and particularly infectious disease, we train for the worst case scenarios. And so while we get a little bit of bristles in our hair, we stay resolute about the things that we think are really important for saving lives and improving well-being. So that kind of message day by day, I think, has been very helpful. And Jonathan and I receive multiple emails a day about hospital status and where things are going. So I think communication has been very clear, and people are just marching forward with a very short-term time frame so that we can deal on a day-by-day basis and adjust as needed.
Right. And Julie, one of the things we wanted to talk about too was thinking about the health inequities that this pandemic has shown a light on. Can you talk a little more about what you're seeing?
Sure. Well, we can talk about Massachusetts, and many of the stories in Massachusetts are being mirrored across the country. My clinic, I'm an infectious disease specialist at MGH Chelsea. For those of you who are in the area, Chelsea is a city not too far from the airport. We have about 40,000 residents, of whom 60% are Latino, and half of our residents are non-US born. And one of the beautiful parts of our history in Chelsea has been our welcoming of immigrant populations over time. So we have a long history of an old Jewish population, an Irish population, and we really are multicultural city. With that, we have many of the challenges that come with not only non-US born populations, but those of very low socioeconomic disadvantage. And those have laid the foreground for vulnerability to this condition. So one, and I frame these comments, and I'm talking about Chelsea because we're currently the highest case count in Massachusetts at 92 per 10,000, which is equivalent to the state average of New York in terms of COVID-19 cases. So we have high population density. Our household composition are dense and intergenerational. And so why is that important in terms of COVID-19? We're learning things that are new every day about the disease. So we know that maybe 40% of individuals will have no symptoms or mild symptoms, but there's also this what's called pre-symptomatic phase. So individuals may have no symptoms, 2 to 3 days before they have cough or fever, but they're still shedding virus and actively infectious. So when we have households where there may be children who have mild symptoms or individuals who have no symptoms, and they're congregated in close conditions, it's like wildfire. And then the other layer is that about 80% of our citizens in Chelsea are essential workers who lack the luxury to be able to adhere to physical distance. So we're emblematic of I would call multi-level inequities that go from the individual to the community to the structural environment. And these are mirrored across the state, and as well we see Lawrence, Everett, Revere, Brockton, other communities that are really enriched with racial ethnic minorities, and around the country, Chicago, Milwaukee, North Carolina. So, the only thing that I would add to that is just how important it is to be systematic about how we're thinking about possible inequities. I've mentioned some, and a key component is bringing in as many stakeholders as we can to expand what we think are the key drivers here, so that we can really be as comprehensive as possible.
Thank you. And Jonathan, I wanted to ask you, why is it important to be reporting on the age, race, and location of those affected, and why states took so long? And I know Boston is now doing that. I know some states have taken a while, and the CDC were reluctant. So I would love for you to talk a little bit about why it's important to share that information and track it, and what was getting in the way of organizations, states doing that.
Yeah, it's a great question, and it's I think for people who work in the field that I work in, this was something that we expected a bit of a hammer blow when it came to starting to hear about inequities, because I know that COVID kind of broke time, but about a month ago, we were all talking about COVID-19 as the great equalizer, the fact that anyone, anywhere could get it, and so we all needed to join together to combat this really frightening virus. But I think over the last 10 days or so, the public has really started to understand that that's not the case. That's never, ever the case. And where we are seeing these hotspots for COVID-19, you're starting to see some of the same old rhetoric popping up, which is that this is something behavioral. This is the fault of the communities somehow. Even if we're sort of benignly chiding them, we're starting to see that. But really, the way to understand a disease, the way to understand anything, is by measuring it, by having information, by gathering data, and most importantly, most crucially, being transparent about where that data comes from, how good of quality you have, and what maybe some of the shortcomings are. So transparency is always good in a crisis. It helps us do the big fancy things that you've heard about in the news, like contact tracing that we're seeing that may be coming from Apple and Google. It will help us deploy resources, which is why we talk about why the census is so important. But from a purely scientific standpoint, it is absolutely crucial to have this kind of inequity information because it helps us understand what the disease looks like, how the disease works, and how to stop it. So we know that the most advanced medicines that we've deployed in the last 10 years aren't any kinds of cures or treatments that are unnecessarily all-powerful, but they are precise, they are targeted. They are rooted in the idea that we have a very deep understanding of what's going on in the body and what's going on with the disease. So a case in point is thinking about the advances we've made since 2010 in cancer is mostly down to something called immunotherapy. And the only reason that something like that works in this case of cancer is because we've spent decades, billions of dollars, understanding the ins and outs of every kind of presentation of cancer that we can. So understanding where COVID-19 hits hardest, who's affected most, what kinds of comorbidities that are really driving the risk is the only way that we can have a complete understanding of COVID and of this novel coronavirus, which didn't exist before the end of last December. So the more information we have on who's vulnerable, where it's striking, the quicker we can defeat the disease. But the problem is that it's really hard to get this data. So there's missing data, there are problems with privacy and identification. So if you're going to a hospital that mostly serves privileged people and there are like 3 people that look like you, and one of you has COVID-19, it's not going to take a genius to figure out which of you has it. So we have to protect the people who are most vulnerable. We have to make sure that we have high data quality, which when it comes to something like, you know, whether your gender or your status or your race or ethnicity, we know that we have a lot of missing information, so it's low quality data. And we know that the data aren't reported consistently across institutions. So it's tough to put all this data together in a way that makes sense. It's tough to make sure that we get this data. And then there are obviously systemic concerns. You know, we're living in an age where it seems like it's a good thing to say that you don't see race. And so backed on that, backed on the idea that everybody should be treated exactly the same, irrespective of their gender identity, there are lots of places that don't ask for it because they feel that that's doing a good thing. But the problem is that we are losing detail, we're losing specificity. And the more that we can do that, the more that we can share information and partner with vulnerable communities rather than patronize them, you know, the better and the more quickly and the more efficiently we can defeat the disease.
Thank you. And do you or Julie feel that because of this lack of data, which communities are being most left out, right? Because we're not getting the data in a timely way to know how to help address those communities.
Well, I mean, one point that I would add is, and we've seen this in HIV and in general with acceptance of primary care, you know, health promotion activities. Our health system is really a cultural construct. It's based on what's convenient for healthcare workers to deliver care from usually, you know, 9 to 5, or I'm making, you know, an assumption there. We do have facilities that provide evening care, early care, Saturday care. But the reality is for many of our most vulnerable populations who carry 1, 2, 3 jobs, the ability to come to an appointment is a luxury. And I think, you know, the fact that we are, in most settings, waiting for patients to come to health centers, if they can even get a test, is an assumption that that is either something that they can do or they would do. So I think that we, have to demand from testing to be more accessible and to be community-based, but to really revise our thinking and through, I would say, trusted care providers, health centers that have community health workers in bed, trusted community agencies that have workers that know on a block-by-block basis, families, communities, and begin checking in with one another on a systematic basis and have the capacity to give tests. We really need to reach out to people. I think, you know, what we're seeing is an understatement, and we have wildfire. And it's very difficult to envision a future of containment without actual numbers. And I think, you know, exactly, I just, you know, confirm what Jonathan's saying about knowing our populations. We can't understand transmission without having a better hold. So I would invite us to really think about new models of not waiting for people to come to us, but to, with loving compassion, seek out our populations and really better understand the needs that they have to be able to fulfill what we think are public health guidelines, which are physical distancing. That's, again, another luxury, and we really need to understand how to support that.
And Beth, I'll just weigh in really quickly, just to zero in on the question that you asked, which is who's left out. So if you imagine that in any crisis, you deploy resources to wherever you can think of or wherever you need it most, that's kind of where we are with COVID-19. I wrote this on Twitter the other day, but I think the best way to describe it is It's like knowing that a hurricane has made landfall somewhere in the United States. You don't have any maps, you don't have any information. The only thing that you have to go on are a small flashlight in your pocket and what you can hear, if you can hear the cries of people who are needing help. So right now we are operating in the dark from a scientific perspective and from a medical perspective. We can hear only the most privileged. We can see only those who are around us. But we know that far, far more people are affected. And unfortunately, because of the nature of our work, we are only primed to hear and see those who are most privileged. Those who are less privileged, whether that's because of their race, ethnicity, their gender identity, their immigrant status, where they live, if they live in a rural area, if they live off, God forbid, they live off of the coasts of the United States, we don't hear or see them nearly as well. And so we are left largely without a clue in terms of how, the true impact of COVID is landing.
So this raises a question for me in thinking about, and something Julie talked about, the role of community health centers. So do you see how are community health centers being impacted currently by what's going on? And are there resources being directed their way, since they often serve the voices that we don't hear?
Right. Well, one of the key features in a emerging infectious disease like coronavirus 19 is being able to separate individuals who may be infected and contagious and those who are not. So one of the things that rapidly happened at MGH Chelsea was an evolution from a usual we're like a little hospital. We have an emergency room, we have multidisciplinary specialties, we have primary care, OBGYN, and what we needed to be able to do was transition the health center into predominantly a respiratory infection clinic, which in the past week is what it's become. And I think what that shows is the challenge for many health centers and health systems is to continue basal level care for chronic disease management. Those things don't go away: the heart disease, dementia, substance use, mental health issues. So we need to be able to continue to serve those needs, separately respond to both geographically in an encounter and a highly contagious disease. We have supplanted the usual routine care with telehealth. Mm-hmm. That really reconfigures what we think of the community health encounter, which and a primary care encounter, which is really based on seeing one another, communicating not only verbally but with nonverbal cues, often visiting, seeing patients as families. So that's changed, and not all patients are ready for telehealth, and not all health systems are ready for telehealth. And so it's changing the quality of those encounters. So I think the silver lining could be that yes, many patients need broader access to health, and maybe we will foreshorten or in Zoom time be able to escalate a method of really outreaching patients in a community health center. Not only the one-on-one, but the telehealth, but to really be able to do that in a way that keeps care individualized. I mean, many patients don't have a smartphone, are unable to maintain the bandwidth for a video conference over a sustained period of time. So I think it's created new challenges.
Mm-hmm. Yeah. And I would also think that certainly for some of the elderly, that telehealth also is more challenging because of the commuter need. I mean, the being able to be technologically savvy as well. So that's another population that may be underserved during this time. I wanted to ask a little bit different question and think about the vaccine for COVID-19. And how do you think about the testing for that, the research that gets done, and the equity considerations that go into developing a vaccine?
I'll start, and maybe Julie can weigh in as well. And this is actually where I've been spending the bulk of my work over the last month, 6 weeks. So we have a little bit of a problem when it comes to the COVID-19 vaccine. And let me set the stage for you. So You've probably heard through the CDC or Dr. Fauci mention that the timeline for getting a vaccine approved is probably about 18 months from when this all started. So we're looking at probably August of 2021 before we can have a vaccine for COVID-19 that we're highly confident about. And honestly, that is much faster than we normally do clinical research. It is much, much faster. So we have to acknowledge that science is slow, even at its fastest. We've done, we've broken records in terms of sequencing the virus, in terms of developing, a number of therapies. We have launched a whole bunch of clinical trials. But on the surface of it, number one, science is slow. So that means that people who are unusually vulnerable to COVID-19 will not be able to take advantage of a vaccine, and they won't even be able to really participate in a research study that might give them early access to this vaccine. The second problem is where the vaccines are being developed. Now, Julie and I are privileged enough to be a part of Massachusetts General Hospital, one of the teaching hospitals at Harvard Medical School. It's one of the 10 national centers that really gets to be mobilized for any kind of major disaster, of infectious nature like this. So we get to be on the front lines of helping advance those efforts. But guess what hospital has zero protocols for a COVID-19 vaccine or for a clinical trial? There's no one in the BMC system that has any access to a clinical research study that might give them early access to a vaccine for COVID-19. So if your insurance does not allow you into something like the Partners Healthcare system, or if you have to jump through hoops to get it, which is going to be hard to do in the best of times, much less during a global pandemic, then you have no opportunity to take advantage of early access. And then what's worse is that when a therapy, it does come along, we will not know how it works on safety net populations. We will not know how it works on the most vulnerable communities, most of which do get their care outside of the Partners healthcare system. Now, Partners does serve some marginalized populations, especially those coming out of Chelsea. But the vast majority of folks, rural individuals, older individuals, Black and brown individuals who are non-binary, they get their care elsewhere. And we're not offering those vaccines in an investigational stage to many of those other facilities. So just like we see with many other research, clinical trials, we won't know how this works on the most vulnerable, even though we're seeing devastating effects of the most vulnerable. So they're being left out of any really strong acute care possibilities. They're being left out of clinical trials. And honestly, I think that what we'll find is that the country as a whole, as we start to reopen the economy, will tend to leave these groups behind. So there's a triple whammy that we're kind of in the midst of. I know that we've talked about multiple waves of this pandemic. And unfortunately, even when it comes to the development and rollout of a vaccine, vulnerable communities are generally being left behind again.
So Julie, do you have anything to add?
Yeah, to follow up with Jonathan and I see things often similarly, which is why I love working with him, because I learned so much from his perspective. Both of our work is heavily community engaged. My research uses a framework called community-based participatory research. So the framework on its head says that, or face, is that we are embedded within communities. We change the relationship of academic research to try to, I think, democratize the process, to say, I may have a certain skill set. As well, individuals with their lived experiences have an equally valuable skill set. And what I would say the application here is, which we know now, but we knew this before, is the vital role that community stakeholders play, not only in development of protocols about data acquisition and privacy and confidentiality, but also in protocols about how vaccines will be tested, developed, and implemented. I mean, we know there is a long history. It's called this quality chasm, the 17-year gap between developing an evidence-based intervention and actually getting it into practice. And we know that's highly unsatisfactory. We want to accelerate the integration of science into care. And part of that is to be able to integrate the populations that will experience the benefit of science so that they can tell us how to do it right. You know, what is adherence going to look like? What are our concerns? What are potential conceptions around getting an injection? We did this kind of work and do this kind of work in Puerto Rico around Zika, where we, with colleagues there, were highly concerned that communities were not involved in a vaccine process related to Zika. And we were worried about issues of community trust and adherence to any kind of uptake of the scientific promise of a vaccine. So I would underscore the importance of Jonathan's work and the work that his team is doing in really having a presence in the community, as well as at MGH Chelsea with our research program, trying to solicit people's feedback about what a vaccine would look like. Now we have to be creative about how we get that input. Maybe it's Facebook, maybe it's social media, but we still need those, maybe it's Zoom or WhatsApp, but we need those voices to inform us about how these protocols should be.
Yeah, and now I would imagine that there are potentially things that people could do to perhaps get leadership in hospitals and other places to be more, I guess, intentional around this. Is there something people can do? I can imagine folks on this call or listening to this Zoom would want to know, can I do something perhaps, as an individual to help encourage people to be able to test vaccines on greater populations? Is there anything, any recommendations, thoughts for how people might be able to influence this conversation?
I'll go first. Those of you who are on the call who know me personally know that I'm an individual who always has ideas. I have no shortage, and this is no exception. There are two things that I want you to remember. Number one, remember that what's valuable about the people that are on this call, the more than 500 people on this call right now, is that this is probably one of the only venues that is robustly cross-sector. So I spend my time talking with a lot of, for me, diversity of job and position means that sometimes I'm talking to a medical doctor, sometimes I'm talking to a research doctor, and then sometimes I'm talking to a research assistant. That is what diversity looks like in my average day. And there's still a lot of varied opinions. But the 500 people on this call are incredibly different in terms of the lives they lead, what they're seeing in terms of COVID, the power that they have, how helpless they feel, who's being affected, and a lot of things about their specific identity. All of that matters. But I will say that the people on this call, these 500 people have power. If even 10% of you were able to kind of set things aside, mobilize a response, we could flatten the curve much more steeply, much more quickly with the help of any 50 of you than we could on our own. So keep that in mind. The second thing that I want you to remember is that when we recover from COVID-19, and I promise that we will recover, we're humans, we're inventive, we will bounce back. I would love for you to all to hold on to how helpless you have felt at times in the last 5-6 weeks. And I need you to remember that some people never get to feel any differently. They never get to feel any less empowered, any less effective, or any more effective than these dark moments that we have right now. So no matter how remote you are, no matter how many or how few people who are personally affected by COVID, we will only ever be as safe as the most vulnerable of us. And so we have to find ways, creative ways, just as Julie said, to listen to those voices and make sure that we defend their value. So there are big scale things that we can do. Number one, obviously vote. Vote at the top of the ballot, vote at the bottom of the ballot. Make sure that the voices that you value, make sure that the perspectives that are important to you are represented in our democracy, and that they are able to make decisions that you largely agree with. You probably aren't going to find somebody that's perfect, but find somebody that gets you and talk to them. So don't just vote, but also communicate. The second thing that might seem a little weird is to do the census. So that's gotten a little bit buried with all of this COVID stuff, but it really is important. It feels scary and invasive, and you can do it online, which makes me feel a little bit weird. But it's really the only way that we can appropriately allocate resources. And we know that the most vulnerable folks are living in communities that are the most robust and that are changing the most quickly. And if we don't update that information, we won't get resources to them, not just during COVID, but any time after. But maybe you're looking for something that's a little bit more specific. I'll run through a quick list of options. Number one, the most selfish thing that I can ask for you to do is consider getting involved in medical research. There are a ton of research studies that are available online. Clinicaltrials.gov, so clinicaltrials.gov has a comprehensive list of every COVID-19 trial. Most major academic medical centers, again, there are some notable exceptions, have some kind of page where new trials are being added literally every day. They're looking for people with symptoms, people without symptoms, people who have recovered, people who have yet to be exposed. So please consider getting involved in that. The number one thing that you can look for is to really demand transparency on the information. We talked a little bit earlier about reporting of specific data around COVID. We know that Massachusetts is doing this. We know that Boston is starting to do this. We know that those data are not complete. So look for transparency, demand more from your elected representatives in terms of what they're offering and what they're able to do. And then the last two things that I'll ask you to do, and then I'll stop, is try to support 3 people in your life. Support somebody financially, emotionally, musically, physically, technologically, historically. Whatever it is that you are doing right now in your life, you have something to offer somebody. Even if you're just bearing witness to someone's story or struggle, whether you're able to give a couple of extra bucks to somebody who isn't able to take time off, whether you're able to offer an extra FaceTime or Zoom call to somebody that you haven't touched base with in a while, everybody needs support. And right now, the most important thing that we can do as a society is to be vulnerable with each other and to support one another. Because the government won't be able to save us all. We shouldn't expect it to. We have to try to do some of this work ourselves, especially ironically, the folks who need it the most. I've got a group of friends who are working on what I think is probably the single most important response to COVID for vulnerable communities, which is they're trying to make sure that there is a more robust backbone and framework around mental health support, especially for peer recovery networks. So if you want to know a little bit more about that, you can get in touch with me personally. I'm going to regret this, but I'll give you my email address. It is jjackson31@partners.org. So that's jjackson, that's my name, 31 @partners.org. If you want to get involved with these efforts, if you have no idea what you can do and you want me just to throw you a list, I'll do that. But again, the most important thing that you personally, individually can do is to be supportive in kind of underpinning, getting trained, offering financial support for these peer recovery networks, especially around mental health. This is the infrastructure that will save us if everything else goes down. But again, feel free to get in touch with me personally if you need a list, if you need an idea to get you started. jjackson31@partners.org. I promise that there's something that you can do.
Great. Jonathan, thank you so much. I think some of us are feeling a sense of helplessness and wanting to know what we can do. And so being able to share what you did is wonderful. I think we are going to, for folks that signed up, send out follow-up information so people have that.
Sure.
And Julie, if there are other things that you have that for actions that individuals can take, please feel free to share those.
I think my first 2 comments, I'll focus on some leadership aspects, and the third about the peer component. One thing that's impressed me so much about the Chelsea response has been the whole of society approach. So every day at 4 p.m., there's a Chelsea pandemic preparedness call. All of us related to Chelsea are welcome to join. There are 11 subcommittees from mental health to something called diversion in activities, which is identifying ways to keep people occupied, to housing. And there is room for anyone who wants to help. And I think, to me, that speaks volumes because of this idea that there's so many aspects to health. There's so many aspects to countering COVID-19. And so one, the whole of society approach. So for all of you who are on the call and have an opportunity to organize in your own workplace or groups, to really think as broadly as possible on the domains that are impacting health, from mental health to environmental exposures to access to care and spirituality. I can't emphasize that enough. The second part that Jonathan, I think, was alluding to is the issue of transparency. So in many organizational settings are now in an incident command structure, which means that it's in many ways a militaristic structure, but the purpose really is to unify the communication channels. So there's one message or simplified message coming out. But what that really behooves institutions to think about is how the information is getting up to the individuals who communicate out. And so that really relies on building structures that require channels back and forth from the large amount of people who make up an organization or community to the individuals who will be communicating and taking in information in and out from the outside world. And so we have this call at 4 p.m. Again, everyone is welcome to join, and we're all learning on a daily basis as to what's changing, what's getting better, what are the challenges in troubleshooting. So from a town that is affected greatly, to have this kind of structure is a microcosm of what can be simulated on a larger level. And then the third item, which Jonathan spoke about, is the peer support, which I think is really a known correlate of resiliency and how we bounce back from adverse conditions, is knowing that we're not alone, that we really do need to rely on one another. And sometimes it's just, I know this sounds so simple, but the mere idea of asking someone how they're doing, but sticking around long enough to really hear the answer. But it's the curiosity for one another. And I hope, again, one of the silver linings is that we'll have more time for that curiosity. I know, in my own clinical encounters with patients, because I still see patients during COVID, we have telehealth visits, and I am starting the visits just asking, how are you? What is important to you now? Really learning from my patients. Not only am I learning new content, but I'm finding it sustaining as well because we're connecting with one another. So I can't underscore enough the value of the peer support and the curiosity for one another. I think that's emotionally sustaining and so critical.
Great, thank you. I wanted to leave some time for questions. So folks want to send questions, and I'll try to pick out some questions to ask in our last remaining minutes. While I'm waiting for questions, Julie and Jonathan, I know one of the questions that came in beforehand was somebody wanted to know, what do you think the world and the new normal will look like once the curve has flattened and we might be 3 months or 6 months removed? How might our lives be different?
Well, a lot of that, I think part of the anxiety with this is the sense of uncertainty. And part of that is driven by, for those who are able to adhere to the public health, and part of it is wanting the individuals who have authority over many of these procedures, or how much they're tapping into the community needs. I think we'll learn a lot over the next couple of weeks. I mean, even with the science in terms of understanding how we'll learn about immunity will change. So I think I am also thinking about, I'm an inherent optimism, not that it's tethered to some naivete, but really because it's our only way out. And I'm hoping that we can have more forum that have 500 plus people where we can begin to think, how would we reimagine or re-engineer the type of society that we've wanted. We need to one that addresses historical injustices, provides resources to those who most need it, and make sure that we have equitable inclusion of stakeholders. So I think there are enormous opportunities. It's going to really be, I think the responsibility is also on all of us when we're not necessarily seeing the change as fast as we may want it on a more official level, that we begin to think as local stakeholders how we can make that societal change happen and push for it.
Great. Jonathan, anything to add about what the future, the new normal may look like?
Yeah, I will try to be brief. I think that the number one thing that is likely to happen, we'll start to see signs of this in 3 months, we'll be fully in the swing of it by 6 months, is that we will realize that so many parts of our day-to-day lives and so many parts of our work infrastructure, our banking infrastructure, our life infrastructure, needs to be more flexible and more dynamic. And I think that a lot of these shifts that we've put into place, especially around our health, will be made permanent. But I don't think that they'll be made permanent for everyone without loud, vocal, sustained support from the people who are on this call. So like Julie mentioned, telehealth is now broadly available for a lot of folks, and in a way that it certainly wasn't before. I think a lot of that will stick around, but again, it'll stick around for the people who were maybe kind of fine, only slightly inconvenienced before it. It will remain a little bit tougher and maybe a bit more out of reach for vulnerable communities, places that don't have reliable access to internet. I grew up on a farm in Texas. My parents still have dial-up. They think it's fine. So telehealth is not an option for my parents in rural East Texas. And it isn't for many, many rural communities, many nursing homes that don't have reliable internet access, things of that nature. So we need to make sure that as we enter this new era that is likely to be more flexible and dynamic, that everybody has a chance for that, because we know that inequities emerge when systems, large systems, are either inflexible or selectively flexible for some. And if we can make sure that across multiple stakeholder groups, multiple sectors, again, talking to the people on this call, we can make sure that we have that flexibility, that it's offered to everyone. I think we'll all be better off.
Great. Thank you both. And I have another question around access for LEP patients. Can you talk about that? And if you wouldn't mind also defining LEP for all those who don't know?
So LEP is low English language proficiency. I can speak to our institution, which is has now made treatment protocols available online in Spanish, really spent a lion's share of the first part of the response making sure that materials were as available as possible in multiple languages. But again, to echo Jonathan, it's not just the language. It's the way in which encounters occur, and it's the solicitation of patients' preferences and trying to understand what their experiences are. And we know that historically populations of color have been disadvantaged by the quality of the encounter with more directive statements rather than solicitation of their preferences. So I think we're going to need to, as Jonathan said, be creative about delivery of mechanisms in terms of telehealth. Yes, think about language is key. That loan applications can be submitted in languages other than English. But think more broadly than language as a disparity, but what is also embedded in culture and the manner of the human interactions in these clinical and hospital and health system and encounters.
Great. And Julie, somebody asked, how do they access the 4 p.m. Chelsea call?
There is, they can contact me, but I would imagine that on the chelseamass.gov page, there is a pandemic preparedness flag. Otherwise, someone can email me.
Great. Another question around small foundation has limited resources, maybe $10,000, wants to know what where might they be able to direct that in your thoughts to be most impactful?
I'll take a stab at this question. What I think is maybe implied by that question is how can we, make that money go the farthest possible? How can we reach as many families? How can we reach as many communities as possible? And I would really encourage whoever is trying to think that way, that it is not lesser to reach fewer families more profoundly or more deeply. So if there's a way to maybe alter the way that you're thinking about this question in such a way where reaching 100 families for a week is perhaps somehow better than maybe reaching 10 families for a month, that we try to think a little bit more about what equity can and does look like. Unfortunately, the state of nonprofits in Boston and frankly in America is terribly fractured. There's a lot of people trying to raise a lot of funds to do things that are only slightly different in some cases from each other. So I would recommend that if you have to go it alone, that you maybe try to reach a community that is deeply affected, a family maybe in a community that is not necessarily appearing in the news quite so much, and that you try to reach communities of color, communities that have been disenfranchised, obviously East Asian communities which still are dealing with rampant racism. It's not only happening when you hear about it on the news, especially here in Boston. But then the other thing that I would encourage you to do is to be fast and be flexible and be collaborative. The odds are pretty good that there's another nonprofit foundation that's in the same situation as you. And there's a chance that maybe you could team up and maybe work with some kind of larger organization or funder to increase the funds or increase the reach of those funds. Again, I know lots and lots of groups that are trying to get things off the ground, really bottom-up types of things. And so if you're interested in supporting them, I can put you in touch. Again, I'm happy to give out my email for that. But I would say to think very carefully about what equity looks like and try to reach a group whose voice maybe hasn't been amplified through all this messaging around COVID.
Thank you. And then somebody asked, can you provide a few actionable steps for how to support their most vulnerable employees? I would imagine there are steps that MGH is taking for, or at least I would hope for employees who are essential that are on the front lines. It may not be doctors or nurses, but even people thinking, having to work in the kitchen. So are there practicable, actionable steps that organizations can take for folks that don't have a choice but to be out?
I'm thinking about measures such as paid sick time. We have employees who don't have, for example, earned time that's available. They can't come to work for whatever number of reasons. So giving people the financial flexibility so they're not living on the edge on either a day-to-day or week-to-week basis. Public transportation is a major source of spread, and also one of the ways that many of us have been traveling to work. So thinking, creatively about options for those who can work from home, and making sure that if you can't work from home, which is many essential workers, that they have a mask when they're able to commute. So really thinking, I think, on an hour-by-hour basis of what the experience is going to be like for the employee over the course of the day, and also when they get home, to really begin to troubleshoot as to which moments in their life experience are going to be points of vulnerability. I think these are moments where we want to be accountable to our staff, not only when they're at work, but think about the exposures, vulnerabilities, challenges, as well as the assets that they have that can help them when they are at home, like family that are nearby that can help with childcare and things like that.
Great. Jonathan, any last thoughts?
Gosh, I think the only thing that I'd like to say is, I know a few people have dropped this call. We still have over 400 people, but please don't look away. Don't be unaffected. I promise that as helpless as you may feel, as disenfranchised and unempowered as you may feel, you have the ability to change the course of this pandemic across Boston, across Massachusetts, across America. You just have to know what to do. If you need help, reach out to one of us. We can help you. But please don't throw away your power or underestimate it, because it's going to take all of us to move this needle forward together. And I think that the best thing that we can do is to start to knit together almost a secondary or a shadow infrastructure of support and vulnerability across a number of sectors that is flexible for everyone who needs it. That's how we're going to be able to protect the most vulnerable. But again, we are only as strong as the weakest of us. And if we can't defend them, then we are all going to remain highly vulnerable to whether COVID comes back in the fall or the next pandemic or the next disaster. We have to protect each other.
I want to thank everyone who joined the call, and particularly Julie and Jonathan for generously taking time out of your days and sharing your knowledge and expertise. We are really, really appreciative of this conversation. I know I could have gone on for another hour with questions, just wanting to hear from you both. For folks listening, we will be following up with a recording of the webinar along with links to the resources mentioned and ways to support those most affected by COVID-19 and more information on the systemic inequities discussed. If you'd like to continue this conversation about racial equity and COVID-19 and identify ways your organization can be supportive, please consider participating in YW-Boston's Stand Against Racism campaign this April. You can visit our website at ywboston.org/standagainstracism for more information. And then you can also find more information about YW-Boston's diversity, equity, inclusion programs such as Inclusion Boston and LeadBoston. Again, Jonathan and Julie are both alums of that program. Information on our website. And if you are in a position to contribute to the organization, we would greatly appreciate that to continue doing the work that we're doing and offering opportunities like this. So again, thank you, Jonathan and Julie. It was really enlightening, thought-provoking, and again, for those that participated, that listened in. Thanks again, everybody. Have a wonderful day.
Stay well.
You as well.